This episode of The Benefit Whisper is brought to you by Route 3 Insurance and Financial Services, where smarter benefits begin. If you're tired of rising healthcare costs and opaque insurance contracts, Route 3 is here to help you take control. They specialize in transparent, employer-driven benefit strategies that protect your people and your bottom line. Ready to break away from the status quo? Visit www.fixmybenefitsnow.com and discover how Route 3 can help you build a plan that actually works for your team and for your budget. Employers are funding more of healthcare every year as the costs go up, but too often they're asked to trust this black box. Claims increase, employees get frustrated, prior auths, denials, appeals, specialty drugs, GLP-1s, and network rules all show up as cost and confusion. Today, we're going inside medical management, not to defend the current system and not to attack it either, but to find out why. What does a better model look like? What if major healthcare decisions were made with clear clinical logic, honest economic logic, and fast accountability when something goes wrong? Welcome to the Benefit Whisper. I'm Ralph Weber, and today I am joined by Dr. Gupta, not Sanjay, but Hemant Gupta, a physician executive with experience across hospital medicine, physician advisory work, informatics, utilization review, and medical management. Hemant, I'm going to keep this conversation industry level. And employer focused, no specific company issues, just the large picture, just to help employers to understand what medical management should look like when it's transparent, clinically credible, and accountable. Thanks for joining me today, Hemant.
Well, it's a pleasure, Ralph. It is amazing to be here with you. You certainly asked one of the hottest questions out there. How can we better manage the limited resource or the dollars that we have to have a winning impact across the field? From a medical management standpoint, I see better care happening when the clinical people lead these decisions. The clinical people are leading these decisions because they know the patients really well. They know the kinetics. They know what works. They know what doesn't work. So you have the players in the field. You have this two sides of the equation, maybe three here. You have the insurer, you have the doctor, you have the patient, you have the employer. Like four.
Mm-hmm.
Four. And what I would say is the sort of forefront is how these decisions are made, where these decisions are made. And we would have to go to the point where some decisions, we don't need more than simple, you're within the guardrails of practice. You, doctor, met with your patient. We think the care is needed. It's within the guardrails. We don't need prior auths. We don't need control there because we know it's within the guardrails. Then there are certain things that are more gray zone where people differentiate. Go ahead.
Yeah, sorry. But even within that, those four parties, they sometimes have conflicting interests. Let's use a Milton Friedman type analogy. If I said to, one of my employees who had done a really good job, I said, hey, listen, I'd like to buy you lunch. That person may be thinking steak and lobster, and I might be thinking Wendy's. And I'm using the extreme, but
yes,
do they look at each other differently? Like, what does one side misunderstand about the other?
That's such a great leading question. I think you're absolutely right. The alignment, the clinical definitions themselves sometimes differ. And I would say differ to the point where you're right. One is thinking Wendy's and the other one is thinking, gosh, a steak and lobster dinner. Clinical alignment, it really happens in the companies or the positions where the payer and the provider are working very closely. And I don't want to put this, but I will say that I've had the honor and the privilege to work in the last 3 years in that intersect between some payers and some providers are saying enough of the past, let's collaborate and build the future. And one of the basic tenets of the future is clinical alignment. We will talk about costs. We will talk about pricing. We will talk about the reducing administrative steps. We will also talk about that. But at the core of healthcare really is that patient-doctor relationship and that need for the right amount of care, the right kind of care at the right time. And some of the biggest minds out there you're going to talk about in your series, they will talk about clinical alignment. clinical alignment when it's not aligned. And so policies and prices are out there, but there's a lack of clinical alignment or very limited clinical alignment. You get a lot of abrasion. The patient feels slighted because the doctor thinks this way and the insurance doesn't.
Mm.
They're slighted because they're like, well, how come we want to take this GLP-1, but you can't take it because the policy doesn't cover it? Well, then why? Wait, so did the doctor and the policymakers connect clinically? And that's the disagreement. That's the friction.
Hmm.
How did you
Right.
develop this policy? Who developed this policy? What's the evidence behind it? Did FDA clear it? All of those elements. We need greater clinical alignment with the practitioners
Hmm.
that are doing this work and the policy creators or the regulation creators that say, well, we'll follow this policy. It's performing in this way.
Hmm.
And there has to be interaction on a case by case basis, but insurers and health systems large look at the 50,000 cases of this. They
Hmm.
look at that big picture. And so sometimes there's that disconnect, but in the end, greater clinical alignment is huge. And I think that's
Sure.
one of the things. Pricing is another,
Hmm.
right? And of course, sometimes you have to say no. I would
Yeah.
say provider and patient see each other and they say, you're actually not a good candidate for this therapy. And let's work on the other things that are needed. I'm not saying that as an insurer. I'm saying that as an active practitioner of healthcare. There is consumerism, but then there's also what's best to be proven to be there. And
Right.
we leading healthcare should align on that.
Hmm.
Part of medical management is who gets it and who
Right.
doesn't. And so
Yeah.
the leader of that cannot be the insurance. It has to be a partnership between the provider, the payer, which could be a commercial, right? It could be
Hmm.
a private company,
Yeah.
and that employee that says, yeah,
Yeah.
got all these resources. This is the evidence. This is where we go with it. So that's the sort of, and from there, we build a cost structure, we build a pricing structure, we build a revenue, sort of the supply side and demand side.
Right.
It is absolutely, when that's not aligned, you get all the back and forth.
Yeah. And I've heard you talk about that, Hemant, that the idea that trust requires transparency, not only around the clinical logic, but the economic logic, accountability. So in plain English, and two of my sons are economists. Okay.
Love it.
And I think I must have been Milton Friedman in a past life or something. Actually, one of my sons attended Milton Friedman's son, his last lecture at San Jose State, like his
Uh-huh.
last class that he taught. But anyway, I'm reminded of a story that Milton Friedman, talked about. If you and I are going to have a meal together and we're going to share, okay. Generally speaking, one of us isn't going to have the $10 meal and the other one the Wagyu beef, the $200, right? We're not going to do that.
No,
But if you get 100 people,
yes,
then one person's going to say, I want that Wagyu.
right.
Okay. So it changes insurance, any third party payer, there's that entitlement mentality. So that is, I guess, the moral hazard, to it. And of course, everybody wants as much as they can get. And most people are generally pretty good and they're not trying to rip anybody off for the most part, but they also, we're all influenced, of course, the drug commercials.
Oh God,
US is the only country in the world that has drug commercials. Ask your
it is
doctor, ask your doctor.
unbelievable. It is so pushed down and brainwashed that we
Yeah.
all need these biologics. We all need this. Condition X, go right to the biologic. That's it. No, we skip all of the other things that are impactfully important. Or, whether it's a procedure, whether it's a device, whether it's you
Mhm.
hit a nail on the head, like that area of, I also have to say, with all due respect to AI, there's a whole bunch of Googling, there's a whole bunch of
Oh, yeah.
GPTing of, I am the right candidate and this is the disease that I have, and you
Right.
better do this now.
Yeah.
And we doctors, we people, we're just bystanders in this process. We're
Yeah.
just, okay, order me this or goodbye. This
Yeah.
element is there. It is there. And if we don't embrace the change and the challenge in it, we will will get left behind with the new generation. But
Yeah.
it is that leadership to say, bring me what you found on ChatGPT. Let's talk about it.
Yeah. Yeah.
And
Yeah.
these are not 15-minute appointments. This is where
Right.
you get to the care about your health. Let's
Yeah.
make sure you're doing the right things.
Right.
Maybe you
Right.
can't for that expensive thing, but let's work
Hmm.
on this element. And so when it
Right.
becomes transactional in 15 minutes, how much
Yeah.
can you really address in that much time?
Right. Right.
Really not about writing up a gigantic document that you get
Right.
paid over.
Sure.
It really is about patient engagement, education, and
Hmm.
leadership in
Right.
saying, here are the steps that will really be impactful in your current condition that you're experiencing and helping them change that process, whether it's diabetes or the common chronic conditions that we know
Sure.
across the country.
Hmm.
And I think that's a different mode. It's more like the right word is uh, longitudinal as
Yeah.
opposed to you just had your X and
Hmm.
God, it's terrible and very expensive. Here's some drugs and see you later.
Yeah.
That's not medicine. That is
Right. No, no,
literally
no.
not, I don't consider that caring for people. I see that as doctors with prescription pads. I see that as
Yeah.
transactional.
Yeah.
I see that
Order
as
takers.
costly, actually
Yeah.
very costly, very
Yeah.
costly.
And I hear a lot of physicians, and I hear them
Yes.
talk all the time. I
Yes.
get paid $56 for a 99 213. I don't have time. If somebody comes in and says, I want this, and it's not really radical, which I think is wrong. And I think most doctors are in it for the good. Most doctors, they get into it because they want to cure. Not all, but for the most part, most doctors are. But they're also, I'm not going to say jaded. That's not the word I'm looking for, but
I
the
think they're
system.
Yeah. I think they gotten used to it. Think they
Yeah.
go, this is what I guess it should be. Everyone else is doing it. So
Right.
there's this sort
Right.
of normalization
Yep.
of a way to take care of
Yep.
folks,
Hmm.
people.
Yep.
And that's not my problem. That's the system. Let me do
Right.
all of this stuff and cut all
Yep.
this. I'm just existing and connecting. The point becomes we definitely have to have a paradigm shift in that
Hmm.
area. We have to
Hmm.
build this with the outcome that it's not transactional, it is longitudinal. And then we have to
Right.
build the capacity to do that. Well, how many doctors want to do that? Probably a lot. The point becomes building that infrastructure, that
Hmm.
expectation is part of that journey. And I think we have the luminaries doing it. We've had the big wigs doing it, could have greater autonomy for the physicians to do this.
Hmm.
This concept that you are stuck on 15-minute visits and
Yeah.
AI is generating all this stuff and you're prescribing, that model just quickly does not serve that member. And it definitely does not serve the total healthcare for that patient. And of course, the costs go up. It's very fragmented. And so
Yes.
you just be basically dealing with fragments that cost a lot of money. I
Hmm.
think a lot of the health systems are large hospitals, the large ones. They're building a lot of urgent care centers. Like what
Hmm.
urgent care center? That means when you have an acute problem or mental health or something that's dangerous and deadly, you're going there. Rest of the time, you're fine. You don't need any. So, the
Hmm.
investment, follow the money, where it's going is large acute capacity, large urgent care. I would have to say there are amazing companies out there building health plans and, I can name some where they're really building out internal medicine, primary care, family medicine,
Hmm.
pediatrics. They're building the care the way it should be provided, which is care. And
Right.
what's the name? Is it PACE? Not PACE. What is it? Blank on the name. But they're building value-based primary care. Value-based.
Right. Right.
That's the cost controller, the purse,
Mhm.
where the right things have to happen. If you don't get enough of that, you get a ton of ED visits. If you get a ton of ED visits, you get
Sure.
a ton of visits. You've heard of that whole
Yeah.
philosophy of supply side. We need supply of the outpatient world and the chronic care world because every 1 in 3 Americans has chronic conditions, 1 in 3. Yet
Wow.
the amount of chronic handling of it on the outpatient side has shrunk
Mhm.
the other
Mhm.
direction. And
Right.
so what's taken care of is high cost treatments failed to prevent and it just employers
Mhm.
are seeing the brunt of this expense. And
Exactly.
gosh, our employer should spend maybe 30-40% on building the outpatient wellness
Right.
structure,
Yeah.
directly contracting with that, saying we employees, the 50,000 we have, all are going to be going through these wellness checks and wellness and
Hmm.
mental health. And, you're going to go through this. We're
Right.
going to build for that.
Yep.
Yes, we will never avoid acute, but the largest space is, so, cost plus wellness. Well, wellness is before you got hospitalized with your heart attack.
Yeah.
So that's the greatest area I would probably, as an employer, say, let's go contract with wellness physicians of all
Right.
areas, all mental health, everything. Let's
Hmm.
contract with those guys, not hospitals. And we
Right.
do hospitals, but in sincerity, where can we build a model where it's not transactional? You'll still get paid.
Mm.
You can spend an hour, you're still going to get paid. You can write 2 sentences or 5 pages, you're still
Right.
getting paid. So
Yeah.
I think that would be huge to do. And I would
Hmm.
love for others that you have in the system to say, let's build that kind of model.
Hmm.
And again, has it. They're sort of experimenting with it, but in that model, prior auths do not exist because
Right.
people are actually modeling care responsibly. They are not
Hmm.
here to transaction something. They're
Right.
responsible for weight, blood pressure, A1Cs, God knows
Yep.
all the COPD, FEV1. Like
Hmm.
there's so many conditions
Yep.
that are part of this picture of clinical monitoring, overall health,
Yes.
and not at nine.
Yeah. Yeah. No, exactly. And I had an episode where I had David Schenker and Kevin Schulman. They
Mhm.
wrote, yeah, they wrote the paper on BIR, billing
Yes.
insurance related
Yeah.
expenses, which led to the life of a bill, the
Yep.
43 steps that a bill goes through, and all the documentation required. And it's gotten to the point where and I'm sure you've seen the chart by Steffi
Mhm.
Woolhandler and
Mhm.
David Himmelstein about the
Mhm.
growth of administrators versus physicians.
Yes. Oh, I've seen
100%.
that.
Yeah, 4,800% growth of administrators and 250% growth of physicians in the same time. There was another study, and I'm blanking on the name, but I'll find it. That was just released February of this year,
Yeah.
2026, that talked about each administrative person that you add, how much they bring in revenue and how much they cost in expenses, to a hospital system. It's
I
gotten
would
to the
love to
point.
see that. Yeah.
Yeah, yeah, I'll definitely share that with you. It's interesting. But what it shows is that we've gotten to the point where you spend more time justifying what you did or are about to do as a physician to
Mm.
people that are non-clinical
Mm.
instead of actually just providing the care. That old show, Marcus Welby,
Yeah.
where he would just sit down, he knew all the patients, he knew their families, their dogs, their what they were studying in college and stuff like that. And, you'd go to him and he'd just say, hey, just, take a couple aspirin, see how you're feeling in the morning. But now it's, oh, I want the purple pill. Nexium,
Or
because I want to,
it may be that my clinic is closing at 4:30. But you go to the ED.
yeah, yeah,
It'd be, sorry, you're sick today. You missed your med. I have no appointment. Sorry.
yeah,
I'll see you 2 months from now.
right.
What do you mean 2 months from now? I'm very much in pain now.
Mm.
Well, just go to urgent care. And so, there is this of limited capacity and limited
Mhm,
time and limited resource. And people are like, well, if I'm going to practice, I need to survive. So if
mhm,
I'm getting this much per
right,
patient, I will have to see that many patients to
right.
survive.
Yep.
So the
Mhm,
final cost of care, sort of the reimbursements are, so if we say, well, you get more based off of how healthy they are, we'll give you a bonus, then I can see fewer patients. Patients have much more time with me. We actually go through the stuff. And when you know it's an issue, I already know you. I don't need
yep.
5,000 patients. I got a
Right.
few hundred patients. I know
Yep.
everyone. I know all my patients. I
Right.
know them like memorized. I know them.
Mhm,
So that kind of care is definitely more impactful,
mhm,
highly more preventative,
yep.
service oriented. And that doesn't mean it's perfect.
Right.
But someone recently posted, it was a Nate Kaufman, the luminary, I guess, advisory. He's like 10% of these people who are very sick take 60% of the cost. Well, what about the 70, 60, 70, the other side, where we could really be managing to save on 60% of the cost. So it's like really the 10%, everyone may cross that barrier because they get really sick and really old. But
Hmm.
really, the mass majority are not being well taken care of anyway. And then
Right.
if
True.
you decrease the cost of care for the vast
Hmm.
majority of people, you
Hmm.
might have resource for the 10%. You might
Right.
actually be able to say, okay, fine, 10%. Okay, we need acute care for the 10% or the
Hmm.
critical care for the 10%.
Right.
Wonderful. But the vast 90% are far more effectively taken care of. Look at the bigger picture, which is 9 out of 10 people perhaps are not getting that kind of value-based care, impactful, effective care that
Right.
that they can afford, the
Yeah.
employer can afford.
Yep.
That whether you have a person in the middle or not, it's more about that care. And I would love to be a part of a model. And
Hmm.
then there are certain places where they're doing this, and I've named some companies that are trying to do this. They're super interested, engaged in building it, but they haven't done it at scale to even
Hmm.
move the needle.
Right.
And that's the point is sort of how do we infuse into more of that?
Hmm. Right. So, and I think we're both on the same page. I think we
Sure.
both agree that's the ultimate. That's where we have to get to. Let's shift gears for a second.
Sure.
The term prior auth, it's one of the most emotional topics in healthcare today.
Yes.
So, how do we separate legitimate clinical stewardship from administrative friction, especially with AI, the AI arms race, denials, prior auths going back and forth? How do we separate that and get it straight? What needs to be measured to prove that it's justified? How does a bad prior auth process look like, and what would high integrity process look
A
like?
wonderful question. Prior auths, the history of prior auths, I know from reading and reviewing and experiencing care, I think the main premise behind the prior auth was it's a cost control measure. In history, it has come and gone, and right now it's on. But somewhere in the past, it wasn't there. But the cost control measure comes from, hey, clinical person, when you do certain things, is it meeting within that policy guideline? And the biggest rub is the people practicing are not aware. Many times they're not aware
Uh-huh.
what that guideline states. And some of them that are aware actually are not aligned with that guideline. So then
Uh-huh.
it leads to this process of I am a physician, nurse, practitioner. I'm ordering something and the back office has to deal with how do you get it covered? And so the disconnect has become always, oh, I have to log into a portal, see if it requires a prior auth, submit all this information. Oh,
Mhm.
yes, it actually is within the guidelines. Yes, it's covered and here's an auth number. If you repeat that in a manual way, it can absolutely create fat burden, delay, and cost.
Yeah.
That's how, so prior auth has been done in that format and fashion, whether it's a drug, a service, a
Mhm.
procedure, any prior auth, MRI, anything. But imagine the following where we have an EMR, you have the proof there. You have all of the guidelines and proofs that says these things happen, these things, all of those elements of the guideline actually sit in the clinical space of the EMR.
Right.
And the guideline or practice criteria, the AI, this is, some of the companies like
Uh-huh.
they've been doing or trying to build it where your your guideline and criteria actually have proof in the record.
Mhm.
I'm going to go search for the proof and I'll approve it right there as they're ordering it. They're
Right.
literally ordering it.
Mhm.
So example, Kima, give me an example. Someone has back pain. All right. That's like 40% of America. I don't know
Sure.
it's a really high number. Back pain is treated with, you know, exam, anti-inflammatories, rest, physical therapy. The first step is not an MRI of the back.
Right. Right.
So, the people listening here is I have back pain, order me the MRI of the back. No, you go to your value-based care doctor, spend a
Mhm.
half hour, 1 hour, 2 hours, whatever, get through your story, have them do a physical exam, perform the sort of evidence-based process of treating back pain, which we learn
Mhm.
in residency. Our board exams include these kinds of questions, right? Primary
Right.
care and traumas. Point becomes, it doesn't say go get an MRI.
Mhm. Right.
Point becomes when I do need it, all that data is there. If I'm
Yep.
practicing according to what the American Board of Internal Medicine is quizzing you on every so many
Hmm.
years. The process is the guideline is like, did you do all these things before? Yes, I did. Let's order
Right.
it.
Yeah.
Okay, your prior auth is approved because
Hmm.
you have all this information already documented, already things that you have done. Now, there's certain exceptions. Hey, I'm coming with
Hmm.
back pain. I can't walk. That's a
Right.
different story. I can't sense my feet. That's a different story. They're a red flag.
Sure. Yep.
The criteria actually include those red flags. So if you
Hmm.
documented all that stuff properly and you said, here's your prior auth, whether we did it
Right.
electronically or not, you document you practice medicine the way it should be according to the
Hmm.
guideline.
Right.
Prior auth is simply double checking. And
Yep.
again, I could say the vast majority of the mostly approved prior auths,
Hmm.
it is not that the people are not practicing that way. It
Right.
is clinical information
Hmm.
that did not get to the insurance that then led to the friction of a denial overturn. That is happening millions of times daily,
Hmm.
millions of times.
Yeah.
Talking all insurance, it's happening millions
Right.
of times daily where that, so I'll stop. I'll stop.
Yeah. No, no, I mean, that's a great point, Hemant. And when I had Mark Cuban on the episode just
Yeah.
recently, he made a great point. When
Yes.
you look at and I have absolutely well, I shouldn't say that. I could probably figure it out, but tens of billions of
Yeah.
dollars
Yeah.
that pass through the payer infrastructure, delaying for a day or two or three, the float that can be made on that
Oh
money,
God.
the friction for the slow movement. As Mark said, I mean, that in itself makes a ton of money. So just slowing down the flow of money in itself is a profit center. So the cost
That's a
containment,
barrier to change. Why would
yeah,
someone change?
exactly, exactly. And that's the thing. So there's so many issues. Now you've also worked around peer-to-peer reviews,
Oh,
secondary reviews, appeals, etc.
I've
What
written
makes an
courses. I've
appeal?
been
And I had
thousands of
war.
decisions.
I'm sorry.
I've written courses on how to do peer-to-peers. For
Okay.
United Healthcare, we had a 8-hour training program on how to perform peer-to-peers. We built a
Mhm.
whole CMO playbook, a playbook. Before United Healthcare, I was at Sound Advisory Services. We built the way to do a peer-to-peer, the way to do a review. How do you
Mhm.
win peer-to-peers? I think there's a whole community of
Right.
people that have built this content. But keep going. Yes.
Yeah. What makes an appeal process clinically meaningful instead of just bureaucratic?
Excellent question. When we practice medicine, there's certain things that are gray zone.
Uh-huh.
The gray zone, it's not black. People ask me this all the time. Oh, 1 + 1 = 2. Why not? If it was that clear, you would just have a robot taking care of you. There's a
Yeah.
lot of gray zone. Argue why we need this. Why couldn't we do these other things? Because it's not black and white. It is not black and white. So
Mhm.
the peer-to-peer calls, we should not be reserving them. And this happens every day, not to hurt anyone or say against. It happens because the initial information wasn't distilled, wasn't available,
Mhm.
wasn't read through. We're doing this at mass scale, right?
Right.
So this isn't by the way, this is all payers, all provider. It's the field.
Right.
The information wasn't distilled. The two doctors talk. They're like, tell me what happened. This. They're talking. It's like a
Mhm.
5-minute call, 10-minute call,
Right.
sometimes even 1-minute call. It's very quick.
Mhm.
They talk about this is what happened. This way. Oh, okay. Approved. Done. This literally shop talk, two engineers talking.
Right.
Okay, no, I can't. I'm not seeing it here. We could be doing these other things. I'm sorry. We cannot approve this, but you have all these other options to do. And they leave them with that sort of, there's a way to actually do that well,
Right.
professionally with love
Right.
and dignity.
Mm.
And then there's a way to rant about it and put
Yeah.
it out on LinkedIn. And I'll tell you that is not the right way because you'll be talking to that doctor again. You'll be talking again.
Yeah.
And that
Well.
that process doesn't work. So we have built this process of how do you
Mhm.
do this? How do you help people? When you say yes, do it in a loving way. When you say no, do it in a loving way and figure out what are the other things that we could do with that patient.
Right.
That's again so the
The
peer-to-peer, then the appeal writing, appeal letters write the same thing. And we learn that there's some cases that get debated at higher levels because there's evidence for and against a certain
Sure.
process.
Yeah.
And then some of it is really just information discovery
Mhm.
that says yes. And they also say no. And so
Right.
my training, when I train physicians how to do this, this is not in residency. This is not in medical school. This is not in fellowship. This
Mhm.
is not, period. We
Right.
train physicians on how to do this on payer and provider side, doesn't matter. It's simply a court case. It literally is a court. Why the other side? So argue me why it's approved. Argue me
Right.
why it's not approved. Argue me both sides. What are the salient features that brings quality, safety, efficacy? And then make the best decision that you can with the data that you have. That's the
Wow.
best you could do.
Yeah, that almost makes sense. And the three
Yeah.
the three words in healthcare that cause the most inflation
Yeah.
are "I have insurance."
You're so right.
You get a dent on your car door. You go to the body shop. You say, "Hey, can you work out this dent?" "Yeah, how are you paying?" "I have insurance." "Oh, we've got to replace the door. You're going to
Everything.
need alignment, new tires, quarter panel. I'm paying cash. Oh, a little bit of Bondo. We can buff it out, right?" Yesterday, I had a plumber come. I had a leak. My ceiling, like there was water coming through, and I'm paying. There's no insurance, right? And he just looked and he said, "Yeah, probably the wax seal," which is like a $5 part. Of course,
Yeah.
there's labor. And I know what that means. I know
Yes.
I've replaced wax seals. Makes
Yes.
sense, right? Now, if I had said, "I have insurance," what's this? Oh, we're going to have to rip up the ceiling. We're
The
going to
whole
have to
ceiling.
push
Yeah.
the
Yeah.
flange up, tear, like do a renovation. We have to we have to be mindful of that too. So let's talk about the employers and most commercial plans, other than Medicare, Medicaid, et cetera, are ultimately self-funded, even if they're even if they're one with what we call the BUCAs, Blue Cross United, Cigna,
Sure. Sure.
Humana. They're ultimately self-funded. So for a self-funded employer where the employer is ultimately funding the claims, what visibility should a CEO, CFO, or even an HR leader expect when care is delayed, denied, redirected, or appealed?
That's a great question. If I was an employer and I'm funding the plan, I would want to know transparently, the transparency that's there.
Mhm,
Uh, from a cost perspective, how many of these are happening?
mhm, right,
What are the conditions that are, this is again, cost, quality, clinical. I would want to know the approved care, the denied care, the clinical information there, the amount of cost per claim. Did the claim happen accurately? All of the sort of the soup to nuts of what the insurance is doing because
mhm,
it's going through the insurance. So how
right,
are you administrating this? How are you adjudicating this? What are what are the clinical policies that you're applying? And then as a doctor, I think about the consequences or the opportunity cost of not doing. So,
right,
the opportunity clinical cost of, or the complications of not doing of.
mhm,
And I would love to know those things because the cost of care, the total cost of care is what I really care about. I really care
right,
about how much it's actually costing me year on year.
mhm,
So I would say greater transparency is needed beyond what is currently being there, beyond what's currently present or available. And I would love to know if there's something that can be done to decrease the administrative steps. That
right,
cost, the avoidable cost is the administrative steps. I'm not looking for an all or none phenomenon. As an employer, there will be care that is wasteful, that is not impactfully helping my employee. And you could be like, well, that's your doctor that's maybe coming up with that, or there's consumerism
mhm,
that's coming up with that. Becomes there are systems in my past, I hate to say it, they're more stringent on their own employees' care than when it is they're not their employees' care. So just I've seen the reverse bucket where I'm an employer, I don't want to spend much more, so be more stringent versus, and let's say I'm a hospital and I have
mhm,
my employees, right? You should not be stringent with the people that don't work for me
right,
because
yeah,
you can pay me for all that stuff. But when it's my own employees and it comes out of my pocket,
right,
let's hold on. What are you talking about? I challenge how many things you're approving. I challenge the total cost. I challenge
mhm,
because they want to save money.
yeah,
But on the other hand, this person is not my employee. They should
mhm,
20 grand for this case. Like, the point is,
right,
you paid us 15. Where's the other five?
yeah,
It really is about costs. It really is about the kinetics
yeah,
of doing that 20,000 times and what is it
and it
are you on?
It is, absolutely, and I've done a lot of health plans for health systems, hospitals,
Right.
et cetera. They are much higher utilizers of
Yes.
healthcare
Yes.
dollars than anybody else. Their drug costs are higher, their everything is higher, and maybe it's just that, maybe it's just that, or maybe it's the availability. I haven't figured it out yet, but I'm usually able to kind of reverse that through intelligent plan design.
Yes. And I would say transparency in the how it's trickling through the system.
Right.
And you can see the approvals, you can see the
Mm,
denials, you can see the why, you can
yep,
see which policy went into effect when and what it did
right.
to the remember, if you decrease the price of something, everyone will want it. So it's this
Mhm.
sort of it's this process of
Yeah,
understanding how that engine is turning, where the dollar
right.
is going, and following it
Yeah,
through. If we're not transparent, we get this black box, opaque process.
right.
We can't follow the trajectory year on year of
Mhm.
costs.
Right.
And that's a big question at hand. How are we going to make it more transparent, make this
Right.
process more transparent? Because I think employers care about where these things go.
Mhm. Right.
That I can't say it will serve 100% because some people
Right.
will be upset because they actually
Sure.
didn't need that. They didn't need it.
Yep.
They're upset. They got delayed because it wasn't time for it.
Right.
We need to lose weight. You don't go to gastric bypass surgery now.
Right.
You
Sure.
do
Yeah.
a whole program that then
Mhm.
it gets you to that process. So that's the point is it's some of it is truly needed to be slowed down, the care
Mhm.
and some
Right.
of it we should not be in front of at all. We should good to go. We don't need the power. We don't need to slow it
Yeah.
down. We should just go get it because you need it.
Right.
We employer want you to do this.
Yep.
Great questions. I think we absolutely, if I worked for an employer, would
Mhm.
love to break down and sort of narrow down where we really need to tighten the screws to slow things and where
Right.
we need to untighten it clinically and financially
Mhm.
evidence based. So
Yep.
it's where we need to loosen things
Mhm.
because resistance is too much. It's actually it's negatively impacting that employee.
Sure.
So,
Yep.
yeah, this is part of the fiduciary responsibility, and I
Mhm.
think employers should be into it.
Right.
Employers should own this.
Yeah. And ultimately they do because in a self-insured plan, the employer is the insurance company.
Sure.
So, anyway, listen, we could go on for hours. So much to talk about. I'd love to have you on another episode, Hemant. For the employers that are listening that
Yes.
feel trapped between the rising cost, the
Yes.
employee frustration, and
Yes.
a system that's hard to see. What's the practical first step, and how can they follow your work and connect with you if they want to talk to you about this?
Well, Ralph, I would leave my name number and my email and my LinkedIn posts out there, but happy to connect with them at any time to consult with them.
Mm,
I would definitely dig into the data and add more data discussions with with the insurance and
mhm.
say, we want this pieces of data followed along.
Right.
And the insurances have it. They actually
Yep.
have the data.
Yeah.
I would push upon them to share that data
Mhm.
and really not so you'd have the financial piece, but you'd also should study the clinical piece of it. I
Right.
couldn't address that more. I couldn't say that more because some of the discussions is all around costs of unit costs and just pay for the volume. But the
Right.
question to really ask is what is the responsible set of dollars from a clinical standpoint that need to be spent that should never be delayed or denied and
Right.
what area do we absolutely need to control more because
Mhm.
there's a lot of fluff there.
Yeah.
There's a lot of fluff where it's not going to help and we're spending all this money. So
Right.
acting in a fiduciary responsibility, the clinical hat should be there. The
Right.
financial hat, absolutely contracting and
Mhm.
regulatory hats all have to be there. But I would love to work with employers that are listening
Right.
to really do the next step, which is get inside your data, get inside the process
Mm.
and ask the right questions because it's up to you to really sculpt the next contract, the next
Right.
cycle contract.
Yep.
Don't take no or status quo as an answer. You
Right.
actually need to double click and dig in.
Yeah.
And I'm there to help them.
Okay. Well, great. Well, thank you, Hemant, for joining the Benefit Whisperer today. I appreciate you helping make a complex part of healthcare just a little bit clearer for employers. Thank you for being here, and I'd love to have you on another
Ralph,
episode.
it's an amazing pleasure. It's an honor to do this. Thank you so much for your time.
Okay. Thanks.
Bye.